Is there any better video?
No, there is a website, but I probably won't have time to.
Go through
Okay.
my browser.
Try this forward, backward. Yeah. Yeah. And we have.
Yes, we can use the laser pointer. So you can use this one to highlight, press and hold it, and move it around. Choose yes.
That's this website to try. And I just.
Oh, okay. So, oh, yes, this is for you.
Cold water.
Yeah, we have a remote keyboard over there. So we swap through different screens. For example, right now we have a screen laptop and we show a video show. And then afterwards, after introduction, we will switch it over to and you can control it through the keyboard and through the flip screen. So you would you stand here and use the microphone here? Okay.
Or you want to use and please hand on.
Okay.
Okay. Can I?
Gosh.
咁樣呢個呢個網絡先。
要熄咗佢先。
哇！熄咗佢先。
係啦，開咗但係 OK 得 OK，咁可以掹出嚟又得，定係遞俾佢咧？
但係其實喺呢度掹咪就咁掹俾佢。
好，不留呢個喺度。
但我少少唔係好明，要用 stand。係啊。個 stand 應該係冇需要，因為之後有 panel discussion 就揾你啊。俾啊
好，
就永平咁所以咁樣咯。
將呢個轉翻去睇劇，即係咁樣夾唔得，即係咁樣係俾唔到嘅，冇人爭，所以夾翻個頭，但係夾翻個頭咧又會好全方。
係，不如我放個 video 先。
你哋明咗先，我哋而家翻去啱咗啲衫嘅。
The whole set.
帮我删那个文档。
佢哋仲有個 VIP 未到，
仲有又播片先。
係 ，OK。
咁我唔識播片，戇居3蚊幾鐘睇。
因為都 photo 當片㗎嘛，唔係喎，但係Sarah 話佢需要我。
咁我哋影完相仲播唔播？
播啦，就成開始。
係咯，點解佢好快咁3蚊幾鐘？
咁就可以啊，咁樣。最緊要就編個台。
哎呀，又来了，这次空气，当年空气，谢谢财神。你看我最初，我的菜，我的菜的手法。我don't Ready, 1, 2, 3. One more, 1, 2, 3. OK， 你不要修稿，我自己知道。好吧，好的。
Still 1 more minute. Okay, good afternoon, Professor Chan, and Professor Chen, Professor Ferreira. Ladies and gentlemen, my name is Qingyan Chen, the Director of Purdue Academy for Interdisciplinary Research. I'm very pleased to introduce our seminar speaker this afternoon. That is Professor Manuela FERREIRA, who is a professor and a program head of musculoskeletal health at the Georgia Institute for Global Health. The Georgia Institute is a global medical research organization headquartered in Australia with an office in China, India, and the United Kingdom. So before joining the institute, she was a professor of Musculoskeletal. Sorry, I just find this word difficult to pronounce. At the University of Sydney. So you always work in a top university. Congratulations. So Professor Ferreira is her work is highly relevant to many of us, including myself. Particularly those who spend a long time sitting around and in the office, okay? Because you sit in the desk and then it's likely you will develop into low back pain. And she is the top expert in this aspect. So in her career, she has already published a lot of papers. And the problem, low back pain, it's already the increased rate of 50% between 1990 and 2015. So in a quarter of a century, increased by 50%. That's not a very good news for us, by the way. So trained as a physiotherapist, Professor Ferreira brings the practical insight to her rigorous scientific work. Her research covers the mechanisms, prognosis, and management of the musculoskeletal disorders. She collaborates extensively with researchers and healthcare professionals in the world, examining a broad range of intervention technology, from exercise therapy and spinal manipulation to medications, radio frequency ablation, surgery, and digital health approaches such as telehealth, text messaging, and mobile exercise apps. So when we experience the back pain, many of us turn to painkillers to ease the irritating and tingling sensation, and I believe we normally do. While it's not a life-threatening, but it can be very difficult to ignore. Professor Ferreira has challenged the long-held assumptions in clinical practice. Notably, her team has shown that commonly used anti-inflammatory drugs, such as ibuprofen, provide only marginal benefit compared with the placebos from the low back pain. This has important implications for misuse of painkillers, particularly in the context of the opioid crisis, which is a phenomenon in the United States, and also bring the tension between US and China. So this is a very important issue because there's already a rising rate of addictions to and overdose death from the painkillers. Excuse me. So Professor Ferreira is the top-ranked scientist in this subject, and she leads multiple major controlled trials, including the world's first placebo-controlled trials of spinal surgery, funded by Australia's National Health and Medical Research Council. She also plays a key leadership roles in advancing the research network, have served in the inaugural chairs of musculoskeletal priority research area at the Colin Institute, a medical research partnership between University of Sydney and Northern University Local Health District. So without further ado, ladies and gentlemen, please join me in welcoming Professor Ferreira. Thank you.
Thank you.
Thank you so much for a very warm welcome and a beautiful introduction. If you don't mind, I'll borrow that introduction from you and I'll add it to my CV. It was really nice. But thank you so much for the invitation. And it's an honor and a pleasure to be here and to present this work for you. I hope you enjoy it. It's part of what I do at work. As mentioned by Professor Chen, I run multiple randomized clinical trials looking at interventions for back pain. So what works, what doesn't work. But before we understand what works and what doesn't work for back pain, we need to know how big the problem is around the world. And this is what we're going to talk about now. I'm going to focus a little bit on the global burden of disease study, which I am involved with. And I'm going to give you examples on back pain and osteoarthritis. So let's just very, very quickly, this is what I'm going to be talking about today. So measuring disease burden. We're going to talk a little bit about why we need to measure disease burden and then how we actually measure disease burden. And I'm going to give you examples in back pain and osteoarthritis globally, a little bit on around Australia, but most importantly around other countries in the world, especially countries of low and mid income. So, first of all, why do we need to measure disease burden? Going back to musculoskeletal disorders, and it is a mouthful, musculoskeletal. We have tried to come up with different names for musculoskeletal, but we still use that term. But what is really musculoskeletal disorders? Musculoskeletal disorders are diseases, syndromes, conditions that affect bones, joints, and muscles. If I ask around the room, how many people here have had a joint pain, like knee pain? Can you raise your hand? Okay. Be honest. How many people have had low back pain? Come on. Yes, thank you. What about neck pain? Yes. Okay. And I can see some people raising the hand all the time, which is not uncommon. So they are highly prevalent. These musculoskeletal conditions are highly prevalent. And when they affect people, they usually come in pairs and sometimes threes or fours. So it's very common for people with knee pain to develop back pain and people with back pain to develop neck pain, etc. So not only they're highly prevalent, but they are, and we're going to talk about it, they are the conditions mostly keeping people out of work. So I'll give you some data, some examples from Australia. In Australia, low back pain is the #1 reason for early retirement. So people have to leave the workforce because they have back pain. And when you think about it, immediately you think this is probably people working with manual tasks, lifting, but not only, so office workers as well. So it's the main reason for people to leave early. Low back pain is among the top 5 reasons for people to see a GP every day. So it is really common, and it does affect people, people's daily lives. But the problem is, why do I know all of this? And why am I here talking about this? Because I've looked at the data. And without data, there is no disease. If you don't have large data sets, and today the talk is about big data, if you don't have big data about a disease, and I'm not talking about hospital level only data or city level, I'm talking about global data. If you don't have big data about a disease, there is no disease. What do you mean there is no disease? Without big data on a certain condition, there is no way you can adjust or appropriate healthcare for that disease. So for health policy makers, without data, there is no disease. Without disease, there is no policy. Now, again, for funders, without data, no disease. Without disease, no funding. And without funding, no healthcare. Big data are also important to highlight areas of unmet need. And this could be, for example, not only in terms of one condition. So we can see that the prevalence of neck pain has been increasing more rapidly over the years. Another example we've just noticed in the latest global burden of disease study, that the prevalence of certain types of osteoarthritis has been, for the first time, increasing more than other types of osteoarthritis. So you can actually assess areas, conditions, and places around the world of unmet need, places that need, and areas that need more attention. Now, of course, we need data to improve health outcomes for those with a problem. So I just told you that one of the big problems with low back pain is keeping people out of the workforce. So this is again, or already, a priority. How do we, and we had lovely conversations during lunchtime today, and I think Professor Zhang has all of the answers for the future for low back pain management, but it's really how do we improve health outcomes for those people? And of course, you need to set priorities for healthcare and for research. So these are just some of the reasons why we need big data and why we need to define a disease. So just a couple of examples and possibly interesting facts for you. Osteoarthritis, it is still not listed in the UN Charter for non-communicable diseases. And in fact, the World Health Organization strategic plan for priority non-communicable diseases does not include any musculoskeletal condition. Don't ask me why, I don't know. I've asked them why. No one can give me an answer. Many countries, and this is another one, many countries still do not have population-based estimates of prevalence of musculoskeletal conditions. And you will see a picture soon. Many countries don't have that information. So this is just to show you that there is huge need for big data in musculoskeletal disorders. So now let's go straight to the global burden of disease. And why is then the global burden of disease important? And we'll probably, the next slide will tell you a little bit about the history of the global burden of disease, but just so you contextualize yourself, the global burden of disease, they started at the University of Washington in the US. So a bunch of people who really wanted to look at data from all over the world and see how a number of conditions, so 259 conditions to be more exact, affected people all over the world. And they started this a long time ago in 1990, so 1990. And again, I'm gonna guess that a lot of people in the room weren't born in 1990. I was young, but I was born. So they started with data from 1990, and every couple of years, they update those estimates. Why? Why is it important to keep updating those estimates? Because we are living in a world of changing demography. What does that mean? We were talking about this today at lunchtime. Certain areas of the world are getting older because we have less people being born every day. So the birth rate has been decreasing in certain areas. In Australia, absolutely 100%. When I first came to Australia, the number of children in a household, the average number used to be 3. Now it's 1. So the birth rate has been decreasing. And because the healthcare system has been improving dramatically over the years, people are living longer. That means that a number of different conditions have been affecting us more than if you look at 100 years ago. So the world is changing. So not only the world is aging, but the population is also increasing, as we all know. The economy is changing, absolutely. And we've seen this with pandemics, recent pandemics. So the economy is changing. And when the economy changes, healthcare systems change dramatically as well. And all of that will determine the patterns of disease and the patterns of disability. So we actually need a platform that we can use to track, to monitor what's happening health-wise around the world. But we can only do that if we have lots of data. We cannot do that with one cohort study, with one cross-sectional study. We need lots of data from all over the world. Okay, now how? That's the tricky one. So before we talk about the global burden of disease, we're going to talk about how you actually measure burden. So The word burden is weight, right? Literally, it means weight. So it's the impact. When I say burden now, we mean impact. So how those diseases are impacting people. If you attended last night's talk, we talked about research impact. So this is really how a disease impacts people. There are different ways you can measure that impact. One of them is by measuring how much it costs. So there are three ways to look at costs. One is direct costs. That usually means how much is spent every year in every country, city, hospital with a certain disease, with the management, with treatments for a certain disease. To give you an idea, in Australia, every year, $5 billion are spent on treatment for low back pain every year. So that's the direct cost. What about indirect cost? This is everything else that you pay for because of a certain disease. So for example, because of back pain, I will miss work for a week, and that's going to cost someone. It could be me because I'm casual, so I don't receive any salary, or it could be my boss because he'll have to replace me with someone else. So that's an indirect cost. It could be also, for example, I need a carer because I can't lift my child because of my back pain. So I need someone to help me. I need to hire someone. That is also indirect cost. Yeah. And then intangibles. This is what you cannot put a dollar sign on. You cannot put a monetary value on, and we'll talk about it soon. Okay, so this is exactly what we were talking about. Direct healthcare costs. It could be hospital costs. For example, if you take knee pain or knee osteoarthritis as an example, it could be acute services. Someone woke up with unbearable pain. They have to go and see a doctor. It could be rehabilitation, physiotherapy. It could be surgery. It could also be outpatient. In Australia, again, back pain, the number of presentations to emergency care or emergency department for back pain, they have been increasing steadily over the years. So more and more people actually go into emergency care, because for those of you who have experienced back pain, it can be quite disabling and scary. And again, there is costs with medications, costs with diagnostic tests, so MRIs, etc. So this is all direct. Now, yeah, okay. What about indirect? We talked about it. Number of sick days, working with sickness. There is a difference between absenteeism, which is when you can't be at work, and presenteeism, which is I am at work, but I have to change my activities because of my back pain, and that costs money as well. Early retirement, carer time off work, time spent by carer, family, and friends. We talked about this. So all of that, these are examples of indirect costs. There are, and I'm not going to go into them, there are very specific ways of estimating and presenting data, big data on direct and indirect costs. And these are some of the examples. I am not a health economist. To be quite honest with you, I'm not very good with money at all. Ask my husband. I'm really not good at money. So this is an area that I don't work in, but it's an extremely important part of any research. And I work side by side with a health economist. For every study that I do, the health economist will actually assess the costs of the treatments, the direct, indirect costs of any intervention that I am evaluating in my trials. But then the next one that we talked about is the intangibles. So remember, we said these are factors or measures that you cannot link to a monetary value. So you cannot be put a value, a money value on these factors. And they are mortality, morbidity, pain and suffering, impairment, participation loss, loss of leisure, quality of life. The problem, as you will have noticed with all of them, these are very, very difficult to measure. So their costs of medication, it's very easy. You just go where you buy to a pharmacy, how much does this cost? Or you go to the government, how much does this cost to the government? Paracetamol, how much does it cost? And then you have that value. How do you measure suffering? That's really hard. How do you measure loss of leisure? That's really hard, and that's very personal. But that is the real impact to the patient. So this is really, when we talk about burden to the patient, that's what we're talking about. And these are just some facts for you. I'm not going to read all of them, but these are just some fun facts for you in terms of, so here, there's a trick. Yeah. So here you have direct costs. Not very good at this. Direct costs. Yeah, there you go. And some indirect costs. These would be some of them for osteoarthritis, for example. Yeah? Okay. Now, this can be a little bit boring, so I'm not going to be spending too much time on it. But I just want you to be aware that now we're going to talk about intangibles. So forget about money. We're going to talk about disability burden and mortality and loss of social participation, etc. There are, again, a number of different ways of measuring those that impact. And these are, in the epidemiological world, these are the common ones. And one thing that you probably would be good to remember is the only reason why we have all of these measures is because the same measure can be used all over the world and across all diseases. So this is a way that epidemiologists came up to actually compare diseases, compare the burden, the impact of diseases, and in every country. I can tell you, for example, back pain, the impact of back pain on a person's life is much greater than the impact of diabetes. That's what I think. But then someone here can say, but I disagree. Someone in my family has diabetes, and I think the impact of diabetes is much higher than the impact of back pain. And then someone else will say, I disagree with both of you, because I think it's actually cardiovascular disease. So to address that debate, because it was a debate for years and years, to address that debate, epidemiologists came up with one measure that could serve all conditions. And then you look almost like a monetary value. You look at the numbers and you actually say, you're wrong. Manuela is right. Of course, Manuela is right. The burden, if you look at disability, the burden of low back pain is much higher than the burden of diabetes and cardiovascular disease. So these are the metrics. The traditional ones, prevalence and incidence, we'll see what they mean. Then years of life lost. So this is how many years you lost because of early mortality. Years lived with disability. So this is how many years you had or you lived with a disability. Disability adjusted life years. That's one of the things that you have to pay attention. So number 4, disability adjusted life years is nothing more than the sum of 2 and 3. Okay? So if number 2 is measuring the impact of death, and if number 3 is measuring the impact of disability, number 4 is measuring the combined effect of death and disability. Okay? So I have a question, a tricky question for the audience. If a condition such as back pain is not associated with death, so back pain doesn't kill you, but it causes disability. All right? So if a condition like back pain is not associated with death, which one is greater? DALYs or YLDs? Who can answer that question? Uh-huh. You'll have to find out by yourselves. Yes, we have an answer. Yes. Number 4. Number 4 is greater. Who agrees? Who thinks number 3 is greater? Who has no idea what I'm talking about? Okay. Okay, remember I told you 4 is 3 plus 2? If 2 is 0, 4 is what? The same as 2. I'm sorry, the same as 3. So for conditions that are not associated with mortality, such as back pain and knee OA, neck pain, the years lived with disability, the estimate is the same as the DALY. Okay? And that's why in those papers, we usually report just one of them. Yeah? So you just have to remember that DALY is death plus disability. And ELD is just disability. If death is 0, ELD and DALYs are the same. Yeah? Okay. Tomorrow I'm going to send you all a quiz, and then I'll ask you if you remember that. No, I'm not. Okay. So this is exactly what we are talking about. Yes, I can move on. So again, looking at the more traditional measures, the first question is, how many people have it? So that's when you have the incidence, the prevalence, the remission, the recurrence. How badly does it affect people? That's when you measure severity, progression. I'm going to go quickly through these because I think this is very, it's very basic epidemiology. What impact does it have on function, psychological well-being, disability, participation? And again, if you're talking about healthy aging, if you're talking about comorbidities, that's what you're interested in much, much more than just the number of people. I want to know not only the number of people with a certain condition, but how it affects people at a population level. And that's the only way to do it is if you measure function, psychological well-being, disability, participation, economic impact, mortality. We talked about this, so I'm going to skip over. I love this picture. And again, it's a classic epidemiology picture. If you go to any epidemiology book, you will see that picture. And it really tells you the difference between incidence, prevalence, recurrence, mortality, and cure. I really like it. So incidence, oops, sorry, wrong one. It's the new cases, yeah? New cases being added to your bathtub. Prevalence is how many people have the disease at a certain time. So prevalence is new cases, but also existing cases. Yeah? So that's why there are more people in the prevalence tab than in the incidence tab. Recurrence, it's how many people had a cure. So this is a hole in the tub. So people are getting cured, they leave the tub, but then they have it again and they come back to the tub. Yeah? And mortality is another hole. As you can see, if a certain condition is linked to mortality, they don't come back, right? It's not possible for them to come back. So that's another hole. This hole is irrelevant for back pain because back pain doesn't kill anyone. But this one, actually, especially this one, is extremely important because we know about 30% of people will actually completely be cured by back pain within the first 6 weeks. But half of those will have another episode of back pain within the next year. So even for those people who get rid of back pain, they will have another episode. So they'll come back to this prevalence tab. For conditions that are very, very chronic, like back pain and knee OA, which one is more important to address, to measure, and to report? Is it incidence or prevalence? Anyone? Okay, I'll do the same. Who thinks it's incidence? Who thinks it's prevalence? Who has no idea what I'm talking about? Okay, we're getting better. Of course, they're both important, but again, prevalence. If you think of impact at a population level, if you think of planning for the healthcare system, it is prevalence, because these are the people who will be going back to the physio, to the GP, to the surgeon over and over and over again. It's not the new people. And in a condition like back pain, where a lot of people get better in the beginning, it's the prevalence, it's the chronic cases that we are really worried about. If I am part of the government and if I am planning a new hospital, I am more worried about those people who already have back pain and will be coming to my hospital repeatedly. Yeah? Okay. Very short break. A certain paper reported that 10% of the population had osteoarthritis. Okay? Which one of the following statements is correct? 10 new cases of OA every 100 days. The incidence rate of OA is 10 per 100 persons per year. The prevalence is 10%. The incidence is 10%. I'll give you 30 seconds to think while I have some water. Okay. Hands up if you think it's A. Okay, let's start again. Hands up if you think it's A. Okay. Hands up if you think it's B. Okay. Hands up if you think it's C. Yeah. Hands up if you think it's D. All right. Now after I said, yeah, I think no one is going to say, okay, why is it C? Because remember I said, if I go back, if I say 10% of the population have back pain, I'm talking about the tub. I'm not talking about new cases. For incidence, you need to talk about new cases every month or new cases every year. Yeah? So when I say 10% of the population have back pain or have osteoarthritis at the moment, I'm counting everyone, new cases and ongoing existing cases, old cases. Yeah? So that's prevalence. Okay. I don't think I'll have time and probably will not have access. But we're now going to talk about the global burden of disease study. This is the website. And up until very recently, anyone could have access or visualize the data. I think now you have to register. There is no cost, but you have to register to look at the data. If you go into that website, you can actually look at all of the estimates, prevalence, YLDs, DELIs, all of the estimates for all of the conditions that they measure in every country that they have data on. Yeah, it's actually, you can spend a few hours just playing with the data. So it's fun. Have a look if you have time. But let's now talk a little bit about it. So as I said, it started in 1990. And two people in the US started, Murray and Lopez. So they started with this idea. Let's look at all of the data in the world and see what's happening, how diseases are impacting. And they looked at communicable diseases and non-communicable diseases. So there are more than 259 diseases that they look at now. The first paper was published in this is actually the first paper on musculoskeletal pain, specifically, was published in the Lancet in December 2012. And again, every couple of years, they renew the data and they renew the estimates and they renew the assessments or the evaluations, the computational evaluations to adjust for the growth in the population. Yeah. In 2021, published in 2023, we had the first, actually the new musculoskeletal series. And I'll wait for you to take a photo because the next, yeah, oops. So these are the papers that were published in 2023 on musculoskeletal. So you have the one on low back pain, osteoarthritis, rheumatoid arthritis, and other musculoskeletal conditions. So all of them are open access. Yeah. So you can have a look at them. Right now, we are in the process of renewing those reports. So we have finished the report on back pain, and we finished the report on OA. The report on rheumatoid arthritis, I think, has already been published, and they're about to finish the one on musculoskeletal disorders. Okay? So those papers are specific reports on musculoskeletal conditions. Now, besides that one, apart from that one, we have the big one. So the big report on all of, did I say 259, 375? All of the diseases in all of the countries. And that was published earlier this year. It's a little bit confusing because you see 2023 is when the data was aggregated. But the paper was published in I think it was end of 2025. Yeah, so it's a little bit confusing, the years. This is a result or a graph from that paper, the main paper, the big paper. And what you can see here is DALYs. So if it's DALYs, does it include diseases associated with mortality or not? Yes, it does. So if it's DALYs, you have the diseases associated with mortality. And that's why you can see at the top there, you can see the communicable diseases, yeah? And then the middle one, the middle cluster, is the cluster of non-communicable diseases. So musculoskeletal disorders is actually down here. It's not very impressive. Why? Because these conditions are not associated with mortality. If you look at YLDs, so years lived with disability, now I took mortality out of the equation. I'm just looking at disability. So the conditions that contribute to disability in the world. Which one is the top one there? Yeah, low back pain. I shouldn't be smiling. I shouldn't be not happy about it, but it is low back pain. So the top one. And it has been the top one since 1990. So for 36 years, it has been the top, the main contributor to disability. Yeah? What else do we have there? Falls. So falls is actually the the fourth one. It's very, very high. And this is at a global level, okay? You can look at different regions of the world, each country, and they vary a little bit, but this is at the global level. Did I tell you that back pain had more disability? Oops. Then, thank you. Then diabetes. Yeah, right there for you. So then you have diabetes, other musculoskeletal disorders. Then at the bottom, you have osteoarthritis, neck pain, etc. And low back pain caused more disability than COVID. Disability. If you look at DALYs, because DALYs has death, then COVID, of course, was associated with a more death than back pain. So it was more important. But if you look at disability, and by disability, I'm thinking people who had to be out of work, people who couldn't participate in social activities, people who couldn't move, back pain is more important than COVID. I'm just, because of time, I'm just going to skip through some of these. These are, we've talked about all of these. So this is just for you to know that this group of people, so the GBD study researchers, investigators, and you can be a collaborator. So, and there are different levels of collaboration. So you can be a senior collaborator, you can be a new collaborator. But these researchers, they have done a lot of work defining conditions and defining what you call disability and the impact that disability has. And these are just some of the examples. Some I'm going to skip because it's not too important. I'm going to skip that one too because it's not too important. This is actually very important. There is one important limitation with these big data studies, and that is the data. Yeah? So if you look at those two pictures are there to show you where the data are coming from, the countries that provide primary data. By primary data, I'm talking about the cohort studies. Yeah? The darker the color, the more data they provide. The lighter the color, the less data they provide. What do you immediately see there? There are a lot of places that provide no data, especially for neck pain. That's a big problem. That's a big, big problem. And if there is one message from today's talk is we need more data. We need more data from here. We need more data and high quality data, big data. And I don't know people who are more well-placed and more capable of getting high quality data than this group here at PolyU. So this is really, it's very important. If there is one message, is a call for action. You need to start gathering data because again, no data, no disease, no disease, no healthcare reform or no healthcare, not reform, you don't need a reform, adjustment. Yeah? So again, you can see that back pain, we have more data from all over the world, but neck pain, it's really, really not good. I'll skip through that. I just want to go through now straight to the results. Okay, so you all know what back pain is. It's the most common musculoskeletal disorder. We know from books and papers that 80% of people with back pain have what we call non-specific back pain. That means back pain that is mostly in the lumbar region, doesn't go down the legs, has no nerve root involvement, and is not caused by fracture, infection, or systemic inflammation. Yeah? So most of it is what we call non-specific. Horrible name. Why do you call it non-specific? Unfortunately, because we haven't been able to, with precision, accurately identify the real cause of back pain. Could be the facet, could be the disc, it could be the muscle, it could be all of them. We are not very good. And when I say we, globally, researchers and clinicians, we haven't been able to pinpoint exactly. We have an idea, but we can't say exactly where the pain is coming from. So we call it non-specific back pain. This is what we found in 2020. 619 million people around the world had back pain. And by 2050, as Professor Cheng has mentioned, we are expecting close to 1 billion people with back pain. Can you imagine what that's going to do with healthcare systems all over the world? That's another very interesting and important information for this group. That graph here shows the prevalence by age. And what you can see, where is the peak prevalence? So now I'm talking about prevalence, not incidence. Peak prevalence of back pain between 80 and 90 years of age. So these are people with back pain, but also with other health conditions. For them, it's more likely that they are on different drugs, medications for other health conditions. And when you're going to treat them, there is a high risk of polypharmacy. There is a high risk of drug-drug interaction. We do know, for example, that some drugs, some analgesics, increase the rate or the risk of falls in older people dramatically. We also know that back pain is associated with other non-communicable diseases such as diabetes. So if you have back pain, you're more likely to have diabetes as well. So can you imagine now the scenario? So what's going to happen in 2050 when we have the peak prevalence at that age group? Well, you can also see that the prevalence among women is higher than the prevalence among men, especially at an older age. And there are some theories. So these are theories, extrapolation. There isn't enough data yet that it could be because of hormonal changes, but it could also be because women in certain parts of the world, women have less access to good care, evidence-based care for back pain compared to men. So it could be a number of different reasons. Okay, this is a kind of repetition from that. We also looked at risk factors. So the GPD will tell you risk factors. And I'll very, very briefly summarize all of these numbers, all of this data. There are 3 risk factors that explain 40% of the disability associated with back pain: high BMI, smoking, and lifting or work-related tasks. These 3 factors explain 40% of the disability associated with back pain. The most important part is, over the years, the contribution of BMI, high BMI, has increased. The contribution of smoking has decreased, still contributes, but the contribution has decreased. And the contribution of ergonomic factors, lifting, has decreased. So population is aging. Population is growing. Population is getting higher and higher BMI. Can you see the picture? Yes. Now you know why we need data. So we talked about this. I'm going to skip. Osteoarthritis, very, very similar figures. A little bit less people living with osteoarthritis, and this is all osteoarthritis compared to back pain, but a lot more people by 2050, so much closer to 1 billion. Again, the prevalence increases with age, impacts more women than men. There is no cure for osteoarthritis so far that we know of. And the top prevalence, or the condition or the type of OA that has the top prevalence is knee. So knee and hip, and then hand. All of these, I'm just going to say, all of these are in those papers that I mentioned before, yeah? If you want to read. So in summary, musculoskeletal conditions, especially back pain, are the main contributor to disability in the world if you look at YLDs. And the 5th, if you look at DALYs, yeah? Because then if you add mortality, some other conditions will be on the top. 1.5 billion people currently live with musculoskeletal conditions, and these are the main ones. But we expect a 70% increase by 2050. That's for all musculoskeletal conditions, yeah? Unfortunately, not all conditions and not all countries have been captured in those big data. So you have lots to do to contribute to that. And we talked about these, yeah? If you want to take a photo, but we talked about them. I'm not gonna quiz you this time, but I am going to thank you very much for the opportunity to share and open to questions. Thank you.
Oh, okay. Yeah, thank you so much again, Professor Ferreira, for this wonderful and a very inspiring talk. Oh, so we're sitting here? Okay, I'm sitting here. Okay.
And I'll sit there.
Yeah, please. We should sit closer, right? Yeah, sure. So we have yes, we have questions.
Yeah.
So this question is from online, right? Am I right? Yeah, probably we should give a priority to be here. So can we take two questions first from the audience here? Okay, so we have one here. Any other audience you have really understood? Okay, let's have the first question first. Yeah, please go ahead. If you want, probably you can tell us where are you from and your name, please.
This is Neil from Food Science and Nutrition Department. And thank you for your talk. You mentioned that high quality data is lacking and you are exploring the opportunities to obtain more. So what do you refer to high quality?
Population level data, consecutive cases, so preferably longitudinal, so not only cross-sectional, but following people up. So getting, again, population data, looking at who has the disease, who doesn't have the disease, and following them up for 5, if possible, 10 years, and getting the data, as much data as you can. So on disability, how much it impacts them, the costs, how much pain they have, any biomarkers that you could add to your data set. And by biomarkers, it could be blood biomarkers, but it could also be imaging biomarkers. So that's what I mean by high quality. So not selecting people to be in your study, but getting everyone. Yeah. It's hard and it's costly, but it's extremely important.
Yeah, second question. Okay, so we have another one here. So you will have a bonus. Okay, we have a certain question on the other side. Yes.
Hello.
Please.
It is nice to attend your conference seminar. This is Shahnawaz Anwar. I am working as a research assistant professor in the Department of Rehabilitation Science, and I'm also senior investigator collaborator of GBD studies. I have contributed in recent MSK studies, which will be published soon.
Thank
So
you.
my study, because I found that there's no national level data of Hong Kong.
Yeah.
So I want to start this that study, but how to approach the data where I start to collect the data from the hospital data, or what are the data required to start the study for the national level data?
So you could use hospital data, but what you have to keep in mind is that if you use hospital data, you will be selecting you'll be including a very selected population. So these are patients with higher disability. These are patients who have had pain for longer. So it's going to be slightly different. You can do it, but it's not going to answer his question, for example. What you need is across Hong Kong, and it could be a survey. So nowadays, it's so much easier. I remember when I started doing research that we actually had to use paper, and we had to go to places and mail surveys to people. Now with online surveys, it's just so much easier to do. My advice would be get a very, very good epidemiologist and get a very, very good data analyst to work with you, and get a little bit of money from your boss.
One small follow-up question, because especially in Hong Kong, the data transfer law is very stringent. It is difficult to transfer any Hong Kong data to other, because in the GBD study we have to transfer data from this to in the database. So how to do this?
You don't have to transfer individual patient data. It could be aggregate data. It could be the summary results, and they use the summary results, so like in a systematic review. So there isn't much problem involved in that.
Yeah, thank you very much. So we'll have the last question. Just a moment, the microphone coming.
He had to go around.
Yeah.
Hello,
Go ahead,
Professor Manuela. I'm Frank from Department of Rehabilitation Science, and I also carry out some big data research. And may I ask how to control the noisy data from some public database, especially some image data,
Mhm.
because like the ANDI or some image data set,
Yeah.
the image is different from we collect. So yeah, I just wonder.
So is your question, do we need imaging data for these studies?
No, my question is the image data from the public data sets is
Yeah.
not very high quality.
Okay.
Yeah,
Yeah.
because maybe they collect 10 years ago.
Yeah.
So the equipment is not advanced like what we collect
Yeah.
and what we use right now.
So again, it depends on your question. If you're looking at burden, you probably don't need imaging data.
Yeah.
So you don't need that for this type of analysis. But nowadays with AI, the use of AI to actually analyze images, whether they are X-rays or MRIs, it's outstanding. And I'm pretty sure your colleagues here at PolyU can help you with that because they are at the top of the technology advances. But there are ways, even when the quality of the data, of the imaging data is not 100%, with the help of AI, you can actually get a lot of important information.
Thank you so much. I think it's a good idea and I will try it later.
Thank you.
Thank you for all these questions. Regarding image, why not try AI? Because older photos can turn into a very beautiful new photos. Just a joke. Okay, so my name is Yongping Zhen. I'm the director of Research Institute for Smart Aging. So in addition to the audience here, actually we have a very large audience online. So on behalf of them, I will ask a few questions here. The first one is how can big data analytics be leveraged to identify emerging research topics with the highest potential for scientific and societal impact?
Wow, that's
Big question.
That's a big question. I think, well, I'll start with big and high quality data is the way to go now, that there is no going back. And again, the era of small cross-sectional studies, I think, is in the past. So if we really want to answer important questions, I think it needs to be big data. How can that shape priorities? Again, we are living in a ever-changing, revolving or evolving world. So we really need to keep up with all of those changes. There is no way you can do that without big data. So I would say definitely it's the big data. And now it could be hospital data. If you are interested in finding out the trends of surgical rates, for example, at your hospital, because it has been changing over and over with the years. So again, you cannot do that without big data. So I think that's how you can use it. Setting the priorities, I wouldn't use big data to set the priorities. I would actually engage with clinicians and consumers to set the priorities.
Okay, good. So a related question, actually, this one actually is quite related to my own experiences. I'm not sure in Australia or different places are different. So the question actually related whether the funding bodies are willing to allocate more resources for those big data collections, like surveying or longitudinal follow-up studies. How about in Australia first? Then I tell you in Hong Kong.
It's a great question. I'll start by saying that the funding scenario for research around the world is not very positive, period. So is there a lot of money? No, there isn't anywhere in the world. In Australia, we are really moving on to research that has more immediate impact on people, populations, healthcare, etc. So if you think about that, definitely big data is definitely a priority in Australia. But you will be competing with big clinical trials, big platform trials that are trying to actually identify what works and what doesn't work. You'll be competing.
Live, maybe something.
Exactly. Yeah. So I think there is, but you will be competing with other people as well, which is probably what you're going to say.
Exactly. You actually answered the question because I have tried, and some other colleagues also told us that, oh, if you do the longitudinal follow-up, probably may not be supported. Okay, for if not direct benefit. Okay.
Can I make a suggestion? I think there are funding opportunities that are more global that maybe could fund these big initiatives. So maybe think big, really think across different countries, how you can leverage the need for big data, not only here, but across, or it could be across different diseases, comorbidities, for example, non-communicable diseases.
This is exactly actually linked to the next question about collaboration. So this question has been actually collected before actually we start this. So start with this big data study. It is necessary to have strong collaboration with a high impact group. How could we initiate a topic so attract many people?
That's a good question. Is it necessary to have collaboration with high impact researchers? I would say you are high impact researchers, so you should definitely collaborate with each other. But it is important to start collaborating with people, whether they are high impact researchers or early career researchers, because thinking is in the diversity. New ideas come when you talk to people who think different to you. So definitely, I would say, in terms of the GBD, is it necessary to actually collaborate with top researchers? No, you can just sign up and become a collaborator of the GBD, and you have access to the data visualization. You're a member, and you probably have had access to the papers, to the reports. You'll be a co-author on the reports. I think Arnold is as well. So you don't necessarily need anything special to be. You're not special. We're all special.
Okay, great. So probably you can prepare to the last two questions we want to ask. Okay, so you can try to, but I have a question very straightforward. I think many of us should be thinking whether regarding, are you suggesting any readings or videos that on this topic to the audience?
I would strongly suggest going to the website and playing with the data. For example, you can actually see in Hong Kong what the top non-communicable disease in terms of burden is. Or you can look at specifically for women or men, a certain age group, what the top condition or the main contributor to not only to disability, but also the risk factors to disability for that condition are. So I would definitely, and the other thing is getting together and writing reports for your area that can be used to advocate for better, for more funding.
Okay.
What better could it be if you actually approach your funding body saying, look, there is no data from Hong Kong. We need data from Hong Kong on these conditions. And the only way we do it is if you fund me. So
this is our opportunity here. Any other questions? If no, then, okay. So we have one question here, please.
Yes, sir. I wanna curious ask about what your specific idea about qualitative and quantitative data collection. You know, I'm from School of Design of PolyU, and I'm currently research urban design in Shenzhen. So I need to interview interview the different roles like tenants, landlord, community staff, and government staff, etc. So I think it's a little bit difficult for me. So I wanna ask about a qualitative and quantitative data research about your idea.
Yeah. Great question. So everything that we are talking about here, we are talking about quantitative data because we want to compare. And the only way you can compare across diseases and across countries or periods in time, the only way you can do it is with quantitative. You know, I have 5, you have 2, I have more than you have less than me. So that's the only way you can do it. Now, qualitative, in terms of impact, qualitative research is extremely important. It's extremely important because that's when you know on an individual level how that disease is actually impacting their lives. You cannot get that from numbers. Okay. You can only get that experience from qualitative studies. So they should come side by side. They answer different questions, but both questions are important and they have to come side by side. I agree with you. I'm not a qualitative researcher. So the methods are difficult. I find them difficult too. But I find it fascinating. We've just finished a study looking at using qualitative studies in Australia, looking at a patient care journey. So we asked about 20 people how their care journey was, and it was just fascinating. So we mapped their journey. So we learned a lot, but again, it's not data that will go to inform the GBD because they're different. Does that answer your question?
Thank you.
You're welcome.
Okay, thank you. So I have the last question that we collect. Then I have one personal question to you. That question is actually, since we have collect so many, no matter qualitative or quantitative data, so you must have a lot of data. So how to effectively process this data? Do you have a team? Do you have an expert or a supercomputer with you?
Absolutely, you need a team. Absolutely, you need a team. So all of these analyses were done using Bayesian approaches, and they're very sophisticated, very specific type of statistical approaches. I can't do it. So it has to be someone who has been doing it for years and years, and they have the know-how. So absolutely, you need a team of statisticians, data analysts, so not only statisticians, but you need people who can work with data, clean the data, audit the data, monitor the data. So you need a data management team and you need a statistical team to work with you. And you had another question?
Yes, I have a question.
Okay.
So you mentioned that for the musculoskeletal diseases or conditions, we have over 1 billion population. And probably many of them are related to low back pain, as you mentioned. So I want to ask a $1 billion question. You mentioned since 1999, the low back pain always on the top. Do you believe whether we have a way to pull it down and how?
Ask Arnold. Arnold has that question. I wish I could say, yes, we have the answer, but we haven't got the answer. I have to say something. So in the past report, and it seems to be a trend that has persisted, the age standardized rates have dropped a little bit. Not significantly, but they have dropped a little bit, meaning that at different, if you take age into account, or the other way of saying this, at any age, the prevalence is actually not increasing that much. And we think that it's because most of the volume of people with back pain, we see that because of aging. Yeah. So when you adjust for age, you see the curve is a little bit flatter. So that's good news. Yeah. At the same time, the population is aging. The population, obesity is endemic, and we know that it's related to back pain, and the population is growing. So at a global level, I don't think we are close to solving that problem. Maybe at a country level, we might be closer. Yeah, but I don't have a lot of
Okay, so I just have
good
follow-up
news.
2 points. Many audience here are probably in online as well, are quite young, at least younger than me or you. So do you have any suggestion for them
Right?
when we getting, when they, like when you actually getting old, so can reduce the low back pain?
I do. And we talked about this today at lunch. I think my suggestion, and we hear a lot about physical activity. Yeah. So you have to increase physical activity, and it's extremely important. But more important than increasing physical activity is decreasing sedentary behavior. So my tip would be, there is no use in going for a run for an hour, but then sitting down for 10 hours. So reducing stress. So maybe your boss needs to relax a little bit so you can have more fun.
Probably in the future, when we have a seminar, they should stand instead of sitting. Okay.
But decreasing sedentary behavior, reducing stress would be my top 2.
So remember, when you go back to office, do not use lift. The first action we need to take.
Yes, that's it. Always use the stairs. Always use the stairs.
Okay. The second point is that in mainland China, actually currently has a campaign starting from kids. But obesity in kids is actually a big issue in China. They have 1 out of the 5 top problems. So now there are many campaigns trying to reduce their BMI. Do you think that will that help?
Absolutely. Yeah, it's a great point. Absolutely. Not only back pain, but a number of other musculoskeletal conditions. Yes.
Okay, so go back to teach your kids as well. Okay, with that, please join me to thank Professor FERREIRA again. Thank you so much. Thank you very much. Thank you.
All right, you have done wonderful job. I really enjoy your lecture and also the Q&A session. So to express our appreciation, we make this a special souvenir for you with your name and the title of the presentation. Thank you.
Special.
Oh, okay. Yes.
Thank you. Thank you very much.
Wonderful talk. Thank you.
All right. I also wanted to thank everyone for joining this seminar. And then, of course, keep tuned for other peer seminars and lectures in the near future. Thank you again. And this is adjourned.
Thank you.